Throughout human history, healing has been regarded as a spiritual event. Although many physicians may now dismiss patients' spiritual and religious concerns as not relevant to medicine, religion and spirituality are associated with a number of healthcare outcomes. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Daniel Sulmasy, director of the Kennedy Institute of Ethics and a professor in the departments of medicine and philosophy at Georgetown University. Dr. Sulmasy has written a perspective article about the role of spirituality in compassionate patient care as part of the journal series on the fundamentals of medical ethics. Dr. Sulmasy, how do you define spirituality and how is it different from a religion?
Spirituality is really about the way in which human beings address questions of a transcendent nature, questions about meaning, questions about value, questions about relationship, and how they live out their lives in response to their answers to those questions. In that sense, spirituality is very broad. All persons can be said to have a spirituality in this sort of very broad sense. By contrast, a religion is a community of persons who have a particular way of living out their answers to those questions, characterized typically by texts, rituals, and that sort of thing that bring people together in a community answering questions about meaning, value, and relationship in relation to questions of the existence of a deity or some other tradition.
And then in what ways is patient spirituality or spiritual needs related to their health?
In remarkable ways. I think that too often clinicians really don't appreciate the ways in which those questions that patients might have about their own value when they're sick, whether they're being no longer productive members of society, makes them question their own value. The ways in which patients will encounter questions about their own relationships. It's uncanny, isn't it, the way in which I think all clinicians know that brokenness in body reminds patients of the brokenness in their relationships. And then there are all those deep questions about meaning, questions about why is this happening to me? Why is my daughter or son-in-law suffering so much? Those questions are always present, and illness inevitably raises those kinds of questions for patients, and they can't be answered by science.
In your perspective article, you discuss the concept of taking a spiritual history. So what does that process consist of, and how would it be integrated into medical care?
Well, one way that I, as a general internist, do this is to, as part of the social history on all of my patients, ask them questions about spirituality and religion in their lives. There are certain kinds of acronyms for methods for doing this, one of which is called FICA. So we can ask whether they have any particular faith or other beliefs. I is for importance, how important that religion or other belief set is in their life. Community, whether they have a community of other co-religionists or other persons who share their fundamental beliefs, and A, how a clinician ought to address these questions in relation to their care. Sometimes, though, the simplest way to do it, particularly among strangers, as we practice often stranger medicine in the hospital, encountering patients for the first time, is simply to relate to the patient as a person. Sit down next to them and ask, how are you doing with this? What are the ways in which you cope? How can we help you in coping? Opening up the possibility of discussing spiritual matters with the patient.
You do say, though, that it's not the role of the physician to provide spiritual care. So who should be responsible for providing that in both the inpatient and the outpatient setting?
Generally, when physicians are caring for patients and we have an opportunity or we see a need the patient has that we're not prepared to address, we make referrals. Now, I'm a general internist. If I make a diagnosis of lymphoma, I refer the patient to an oncologist. Similarly, we are not prepared to address spiritual needs for our patients. We may be the herald who finds it because we've encountered the patient in the depth of their needs as a whole person and really opened up to the possibility of talking to them about those needs. But we would then refer to a chaplain in the hospital, or perhaps if we have resources within the community, the patient's own clergy or other sorts of clergy who are the real experts in dealing with the spiritual needs of all human beings, and particularly those who are sick.
So, a practical question. You bring up the scenario in which a patient asks their physician to pray with or for them. How should physicians respond, and does it depend on their own beliefs, their own spirituality?
Yes, I think increasingly there are encounters that physicians have with patients who will ask for the physician to pray with them. And there may be some physicians whose beliefs allow that, particularly if they're congruent with those of the patient. And I don't see anything wrong with doing that. On the other hand, if a physician simply lacks any kind of religious beliefs and is uncomfortable for any reason in praying with the patient, then I think the physician ought to be able to say, I really respect the fact that you are expressing these needs. I'm sorry, though, that I'm not the kind of person who prays or shares those beliefs with you, but I really want to make sure that your needs are addressed. How about if I ask our chaplain to come in to pray with you? And I think that that's a way of showing respect for the patient, understanding it, but also self-respect and recognizing that the individual physician may not be comfortable praying with the patient.
And then the flip side of that, what about physicians who want to advocate for a particular religion or want to pray aloud for patients during clinical encounters? What ethical issues arise in those circumstances?
The relationship between a physician and a patient is a very intimate one, and it is also characterized by a profound imbalance in power. Patients are very vulnerable. It's one of the reasons why in the Hippocratic Oath we say that we will not engage in sexual contact with patients. We won't divulge their secrets. Likewise, the imbalance in power suggests that physicians ought never, without the consent of the patient, to try to proselytize, promote faith, or pray with the patient without their consent, because it is an abuse of the power imbalance and the intimacy of the physician-patient relationship.
Finally, how would you advise physicians who are worried about asking about spirituality or religion lest they inadvertently offend patients? Why is discussing these issues part of providing compassionate and ethical care?
Well, I think all of us are committed to treating our patients as whole persons, to recognizing that illness is a spiritual event, that it raises these transcendent kinds of questions about meaning, value, and relationship, and that we really have a moral obligation to treat our patients as whole persons and to recognize that they have those kinds of needs as well. So that if someone has discomfort in initiating this kind of conversation with patients, I think that we have an obligation as a profession to begin to try educating physicians, both in medical school at the beginning, or now through continuing medical education if someone is already out in practice, about how to, in an honest, simple way, begin to recognize, address the spiritual issues of patients. Again, recognizing that it is not the job of the physician to provide the spiritual care for the patient, but it is the task, I think, of the physician to recognize that spiritual needs are there for the patient. To respect them as whole persons means that we need to recognize all of their needs and to try to address those through working as a team with other members of the care team.
Thank you, Dr. Sulmasy.